What the Canopy Cancer Collective is trying to do is both incredibly hard and incredibly important. They're actually up against a few hundred years of history of, again, how we train as physicians and historical models of how we then offer care to our patients. Change at that level is very difficult because we, like any other person in any other profession, get fairly rooted in our ways. I believed 15, 20 years ago that I was and even earlier, I was a very empathetic physician. I would have liked to have thought, at least, that I was a very empathetic physician. A family experience being diagnosed with pancreas cancer actually completely opened my eyes to the ways in which the conventional operating mechanisms of a hospital and a cancer center are really challenging to navigate for a family. Even as a physician practicing in that system, once I became a family member of a patient with the disease, you see things through entirely new eyes. And so the model of trying to seek out and find the doctors in the various disciplines, doing that essentially on your own, and trying to get those appointments as quickly as possible so that you know if you're eligible for surgery and when you might go, if you should get chemotherapy, and should you get that chemotherapy before the surgery or only after the surgery? Is radiation an important part of your care plan? Should it be? And so from the standpoint of a patient and their family dealing with an incredibly frightening diagnosis, and then on top of that, having to basically navigate by themselves a complex system to get to the experts that might be able to help them is, I think, unnecessarily daunting for the patient. The other thing that happens is that when each of those disciplines formulate their care plan independently, if I think about the chemotherapy part of care, but I'm not in immediate dialogue with the surgeon and with the radiation oncologist, I might decide to do things in a way that's most convenient for me, or in a way that is the way I was trained to apply that discipline. And similarly for a surgeon and for a radiation oncologist. Now, we can think about each other in the abstract and imagine how those other disciplines would apply their specialties, their expertise as well. But it's a wholly different proposition when you're formulating that care plan with everybody in the room. The first reason is that we are called upon to respond to each other's questions and to being pushed to think about different ways to approach a given patient. So a nurse might point out to us that either the patient's wishes or the patient's condition may or may not warrant a particularly aggressive approach, for example. We may realize that there's a new way or a newer way to combine radiation with chemotherapy because one of the colleagues in the room will have just come back from a conference or what have you and can bring that information to us faster. Being in the room with your colleagues and having to answer to them undoubtedly makes us better. Extending that model to colleagues across the country only amplifies that input and that collective push to basically be better. The other thing that the Canopy Cancer Collective has brought to bear is a very professional apparatus by which we measure processes and procedures, where we can come up with improved ways to increase efficiency. And we can also, in a much more systematic way, identify bottlenecks and problems and solutions to those problems. So the entire apparatus is actually geared towards helping all of us at our respective institutions navigate the peculiarities and the barriers that we might experience locally, but also learn from other institutions across the country. I think there's no question in my mind that that is just going to accelerate the pace at which we all become better at what we do. One of the things that's been very exciting and very gratifying for us here at the Fred Hutch Cancer Center in participating in the Canopy Cancer Collective is the ability to interact with like-minded colleagues at other institutions that have instituted similar kinds of approaches to the delivery of care or are in the process of doing so, and giving us then an opportunity to see how other people might build a comparable system, again, to meet the needs of the patient, and what sort of challenges and hurdles they had to overcome, and compare that to what we might have had. And what I've seen already is that there are fresh ideas, stimulating discussions, a handful of things, of templates and mechanisms of efficiency that other institutions have developed to address specific problems that potentially complement the ones that we've developed. And so what I'm hopeful of is, in a compressed time frame, we can not only, again, elevate our collective game, but also push each other to do this better and hopefully widen the net, hopefully demonstrate across the country and help other institutions that want to apply this model to bring it to bear. I think there is a great deal to be hopeful about now, and in particular in the last several years. I think our understanding of this disease process and the complex nature, the complex ecosystem that the tumor develops. So the way I think about this tumor now is not just a multidisciplinary approach to delivering the clinical care, but a multi-compartment or a multicellular approach to the types of treatments and targets we apply. Putting all of those things together and doing it in the right sequence, I think, is going to give rise to wholly new levels of response and hopefully survival in these patients. And so there's going to need to be a multidisciplinary approach to the way we think about the science of the tumor, in addition to the multidisciplinary approach that we bring to the actual delivery of clinical care. I personally would no longer want to practice pancreas cancer medicine in the silo that I was previously trained to think about it in. And I think all of my colleagues would tell you the same thing. Commit to it for 6 months, and I guarantee you that'll be the new practice model.